A very good afternoon, dear students. Hope all of you are doing well during this COVID times. All of you take all the necessary precautions. Be safe. Today's class is on the biology of tooth movement. Previously, we had online classes, but today, since the last 1 month, we have been recording as per your request. We have been recording and uploading the different classes so that it's convenient for you. And also, students from remote areas may not have access. That is also one reason. So we came into this format. So I would just, today's class is about the biology of tooth movement. This is a very important topic. Even the seniors can exam going. The exams are postponed right now. So again, there is a postponement of the final BDS exams. So they can just refresh. It's a very important and repeated essay question. Today's topic, I'll just share the screen for you. Today's topic is the biology of tooth movement. So coming to the today's topic, it is the biology of tooth movement. Very, very important topic. We repeatedly will see some short questions and major question, very, very frequently seen if you refer the last 10 years papers or so. So today I will just I've split it into the two parts. So the next Monday again you will have the biology of tooth movement part 2. So today we will just go through the different classifications of the tooth movements, theories of tooth movement, then the biological. We will just go into the cellular level of on the molecular level. What are the changes taking place during tooth movement? And of course, the biological consideration, I will refresh what all you have read in your dental anatomy and physiology. So that also, we will just go through that also. And of course, clinical considerations, that will be in the part 2. Okay. So the biology of tooth movement, the orthodontic tooth movement is a complex biomechanical process. So whenever the force is applied, you need mechanical force for the biology, for the tooth movement to take place. So the force, you will have different types of force. We'll come to that the later part of today's class. For forces, we should use only the optimum force. If you use heavy force, there are different changes. Then if you use the optimum orthodontic force or the very light force, then only the tooth will move in a proper manner. So the major tissue changes like the alveolar bone remodeling will take place. As you push the tooth, the bone remodeling will take place. The surrounding alveolar bone and your periodontal ligament fibers, different fibers will reorganize. That is how the tooth movement will take place. By bone, one side there is resorption, and the other side there is deposition. Like that, keeps on adding and it moves to the new place because of the force which we are using. So the orthodontic force that affect the extracellular matrix and the cells of the PDL. The entire periodontal ligament, the alveolar bone, the gingiva and the pulp all will be affected based on your force, the amount of force which you are using. So the orthodontic tooth movement, this is the definition. So after the class, even in between when you find time, you should get into this again, this uploaded videos, and again You should just take down the major diagrams. The important diagrams you will have to put it down on the paper. Then you will have to take down the important definitions. So that is the advantage of this, which all the recordings which are uploaded, the different classes. So you should take down the different various definitions. You can just pause it and take down the definition. Then you can draw the various diagrams in a separate book. So it will be easy during the exams for you to put down the various diagrams and the flow charts. So the orthodontic tooth movement has been defined. This is the profits definition. So when you write down the references for your essay questions in the university examination, you need to put down the text references also. So you'll have to, I keep telling in the final year classes and even the third years, you'll have to write down the important textbooks, the major textbooks, William R. Profit and the Moyer's textbook. Those textbooks you should remember and put it down in, at least for the essay questions, you will have to write down your references. So the result of a biological response to an interference in the physiological equilibrium in the dentofacial complex by an externally applied force. Okay, this force is the prescription. So in orthodontics, force is the prescription. Without force, you cannot move the tooth. So you might be wondering why we should know in depth about the biology of tooth movement. Even though you use a removable appliance, you need to understand the biology. So what is happening down there in the bone, PDL, surrounding structures at the cellular level and the molecular level, what are the messengers released, all this you should be able to know. You should know, and then only even if you use a removable orthodontic appliance in your practice in the later years, you should know what is happening there. Even for the removable appliance, the same sequence will happen. So the pressure side, when there is pressure, there is resorption. So on the tension side, there is position or the deposition. So you look at the force. The force is a linear vector with both magnitude and direction. So it is a linear vector. Force has both magnitude and direction is there. So you have two types. You have a push force and a pull force. Based on your clinical situation, you will be using one of these forces, either push force or the pull force. So the push force, suppose you want to push the maxilla inside the protruded maxilla, you may have to use the push force. Okay. So when the maxilla is midface is deficient, suppose in a class 3 severe midface deficiency case, you need a pull force. You'll have to use the appliances accordingly, which pull the maxilla. Okay, that is the difference. So you have both the forces. So the force distribution is also very important. The amount of force delivered to a tooth and the area of your periodontal ligament over which the force is distributed are more important in determining the biological effect. So the force by area, that is equal to the pressure. Okay, that is a simple formula you should remember. So the bone is being built with your osteoblasts. You can see there. These are the osteoblasts. You must have drawn this in your record books in the first year or so. So wherever there is bone being built, you have the osteoblasts. Then you have the osteoclasts. The bone is being destroyed. Okay, the osteoclasts are there. There will be resorption. So the tooth movement, when you apply the force to the tooth, the PDL is stressed. You look at the PDL, so the periodontal ligament, you can see the entire structure here. The periodontal ligament is stressed. So the compression side, when on the compression side, there will be osteoclast. So the tension side, the other side, okay? The other side, you will have osteoblast. There is bone formation. So that is how there the bone remodels and the tooth starts moving. So the history, a little bit about the history, not much, you don't require much. Sandstead supposed to be the father of, is supposed to be father of biology of tooth movement. So the was and retain these are all the pioneers in the biology of tooth movement. So this is very important. This also the classification of your tooth movement. All of you know what is physiological tooth movement, which you have read the first 2 years. The physiological tooth movement, your eruption, drifting, tooth movement due to mastication. Okay, tooth even moves because of your masticatory forces. Okay, that is called driftodontics. You just leave it, extract one of the premolars and leave it off in a crowded case. Because of the masticatory forces, tooth start moving and it gets decrowded naturally. Okay, that is called driftodontics. So the pathological tooth movement, then you have, all of you know what is pathology by now. We're in the final year. So the periodontal pathology, it may be periodontal pathology, okay, because of the periodontitis or all the different gingivitis, all the periodontal problems. Then you have the cysts and tumors, all these things. These are the pathological tooth movement. But today's class is about the orthodontic tooth movement. Okay, this is today's class. So forget about the physiological and the pathological. Today we will be dealing with the orthodontic tooth movement. So the biological consideration, I just want to brush you quickly through the biological. Yes, supporting tooth supporting structures. All of you know those things. The periodontium, the entire periodontium, what it consists. You must have been already told the third year or so in the periodontal department. Okay, so the gingiva, the PDL, the root cementum, and your alveolar bone. So the gingiva, you have all the different fibers. Okay, some of these fibers are very, very important. Even in orthodontics, okay, you'll have to remember the transeptal fibers. Once the treatment is over, in different cases, in spacing cases, in the midline diastemas, in rotated teeth, okay, you need to post-orthodontic, you need to excise these fibers. Okay, these fibers has to be after you put the retainers and before placing your retainers, post-orthodontic treatment after before deboning your fixed orthodontic appliances, you need to excise those fibers. So the fibers will reorganize the new position. Okay. So the periodontium, you know what are all there in the periodontium, the cementum, the PDL, the bone lining, the alveolus. Okay. So the cementum, I will not go into the details. All this, you know, you just refresh from your the dental anatomy or the histology. All this you have known, you know better. Need to just refresh these areas just to understand the biology of your tooth movement. The periodontal ligament, so you can see there, the width of the PDL is very, very important. Okay, so the width, you should know the width properly. You need to check in the radiographs. Okay, sometimes the width of the PDL decreases. That you will have to identify. So the width ranges from 0.15 to 0.38 millimeters. Okay, that varies according to the location of the tooth and the age of the patient. The aged patient, so the width will again, there will be narrowing. Okay, so the PDL fibers, again, like in the gingiva, you'll have the PDL fibers also here. You have the different fibers, you can see there, the alveolar crest fibers, That is all. That is very important for us. The apical fibers, the gingival fibers, horizontal fibers, and the interradicular fibers. Some of these fibers we need to give some excision. We need to do gingivoplasty. We need to do circumferential supracrustal fibrotomy, post-orthodontic treatment. Then we need then we need to give time during your retention period. You need to give time for it to reorganize so that there will not be much relapse. Okay, the relapse, whatever you do, there is some amount of relapse, but the relapse can be minimized. Okay, relapse will be very, very minimal if you do all these periodontal procedures properly. Then let the tissues reorganize. Till then, you need to keep the retainers. So these are your supracrustal fibers. That is very important. We will get into the details of these fibers. How do you excise these fibers in a rotation treated tooth? Okay, post retention. You can see there that we will deal in the retention and relapse chapter. Okay, so the structure, you can see the structure, the cells, the extracellular matrix. If you see this slide, we have the different cells. These cells you should remember before we get into the basic theory of tooth movement. Okay, the synthetic cells. Okay, you have the fibroblasts, osteoblasts, and your cementoblasts. These are the synthetic cells, the bone forming cells. Okay, so the bone resorptive cells, you can see again you have the same fibroblasts, cementoclasts. Here you have osteoclasts and cementoclasts. Okay, here you have osteoblasts and cementoblasts. That's the difference. The resorptive cells and the principal cells. So the fibroblasts, these are the main heart of your PDL. Okay, the very, very important cells, the fibroblasts. That is the microstructure of your fibroblasts and the fibers, the collagen. We have the type 1 and type 3 collagen. Then the bone, all of you know the bone, the different types of bone, the alveolar bone proper, the alveolar process, then the osteoid. You can see the bone here, the bone tissue. So the classification, these the bones which you have seen during in the couple of first 2 years. You can see the compact bone and you have the cancellous bone or your trabecular bone. Okay, so most of your compact bone, you will see it in the mandible. You can see the compact bone is more. Okay, so some amount of compact bone is there in the maxilla, but mostly it is cancellous bone or your trabecular bone. Okay, the basic difference you should know. So that is why in the mandible, when we apply forces, we will be needing the force will vary in the mandible and the maxilla because of the bone. Type of bone you should be thorough with which type of bone is there in which area. So that is very, very important when you move the teeth. We will not go into the details of that. In the alveolar bone, you can see there the outer cortical plate, central spongiosa, okay, the bundle bone, that is your alveolar bone. You can see the composition of your bone. That also you should refresh the composition of bone. What is what in the 100%? You can see there 5% is inorganic. The 35% is organic. Then you have collagen. Most of it is collagen. The organic. Then the cells. These cells, the OPG cells, and the osteoblast, osteocytes, osteoclasts. Okay. So the bone modeling and remodeling, the Wolff's law. This is a repeatedly seen in the 2 marks area, the Wolff's law. So I want you to write this down. Okay. So when you are going through the class, just pause it at this slide, then write this. This slide has to be there. The Wolff's law, very frequently seen in the 2 marks area. You need to know it thoroughly. And there is a diagram also, the Wolff's law. In the growth and development chapter, we have already told about Wolff's law. Okay, you should, for this slide, you need to draw the diagram. Okay, the stress lines showing the stress lines, stress bearing lines. Okay, so the bone remodeling, so the biological events, tissue reactions during your tooth movement. Okay, the tooth movement. So on the pressure side, there is resorption on the pressure side, and there is deposition on the tension side. So the physiological tooth movement, all of you know, I told you in the beginning, the, the different physiological tooth movements, the eruptions, the theories of eruptions. Okay, don't mix up these first year things here. It's just to refresh you about these things. The theories of eruption, all of you know, the blood pressure theory, the root growth formation or the root formation theory, hammock ligament, PDL, exotropic gel theory. Okay, but the theories of biological tooth movement are entirely different. Okay, so leave the theories of eruption here only. So he is supposed to be Carl Sandstedt is the father of biology of tooth movement. Okay, he gave the first description of the glass-like appearance of the compressed tissue. Okay, when the heavy force is used on the bone, on the tooth, so when there is severe compression, the bone will appear like a glass-like appearance. That is called your hyalinization. Okay, so the orthodontic force, so the basic orthodontic force is should not be greater than your blood pressure, the blood capillary pressure. Okay, that is the basic. Okay, you should remember this. Okay, so the optimum orthodontic force is 20 to 26 grams per square centimeter of root surface area. So even the current techniques, when you come to the 20, if you take 2020, the recent appliances they are using, even this is the optimum orthodontic force, but till now they are using very light force. It is only 2026, but still now they are advising for some appliances, self-ligating appliances they are called, they are using only half of this. That is around 12 to 13 grams per square centimeter of root surface area. Okay, these are the recent advancements. Okay, if you remember, that will be good. So the different events that follow after application of your orthodontic force. Okay, this is at the microscopic level. What all the things happening once the force is applied, the alteration in the blood flow. Okay, the blood flow is reduced. There is alteration in the blood flow and the reduced oxygen level, and at the compressed area there is reduced oxygen level. There is increased oxygen level on the other side, the tension side, there is increased oxygen level. So coming to the theories of the tooth movement, we have the pressure tension theory, the classic theory or the hypothesis, the bone bending theory, the piezoelectric theory, the fluid dynamic theory, the second messenger concept in orthodontics, the mechanosensing, transduction,